So I'm Dr. Fathia from Tunis, and I'm really glad to participate to this meeting. I really thank the organizers for the kind invitation, and I will speak today about hypertensive emergencies. I think it is an important topic, and we'll discuss how management and diagnosis need to be nuanced. Hypertension is an obligatory public health problem, and with 1.3 billion people in the world that are hypertensive, most of them are not diagnosed, unfortunately. And even when hypertension is diagnosed, only few of people are at target and well treated. 1 to 2% of hypertensive people suffer from a hypertensive crisis during their lifespan. In a practical way, when we are in face of a high blood pressure, usually more than 180 to 110 meters per mercury, millimeters mercury, first step is to measurement errors, and they are very frequent. It is very important to lead to misdiagnosis. After eliminating measurement errors, there is two situations. Either the situation is chronic, and we will rather resistant hypertension if the patient takes already medications, but there is people who are in a chronic situation, elevated blood pressure, more than grade 3. In an acute setting, we will speak hypertensive crisis, and we will distinguish hypertensive urgencies and hypertensive emergencies. Hypertensive urgencies are not immediately life-threatening. Their management is ambulatory after an observation time, while hypertensive emergencies are immediately life-threatening and needs ICU management. So in a hypertensive crisis, there is two really distinguished entities, but when the patient presents to the emergency room, for example, we have to make a nuanced diagnosis to recognize in which entity the patient is. The emergency, hypertensive emergency, is defined by an elevated blood pressure more than 180 to 120 or 110. That is a bit different in papers. But the more than the number, it is the abrupt elevation of blood pressure that is important. The number is really arbitrary and it doesn't have any scientific assessment, so it is arbitrary. And the most important thing is an abrupt elevation of blood pressure. And when there is, with this abrupt elevation of blood pressure, there is a target organ damage. Here we speak about an emergency. For French people, there is false synonyms because we speak in French about urgence hypertensive, that are not urgencies but emergencies. So let's see this clinical case. It is a female of 72 years old and who has hypertension from 25 years. She has diabetes mellitus and she's current smoker. She takes 3 antihypertensive medications and a statin and metformin. She was in visit to her son. She came to the capital for this, And when she was in her son's home, she took her blood pressure and it was elevated, 195 over 120. She verified this many times and she found the same level of blood pressure. She missed the last evening intake of her antihypertensive medication. She is on low sodium diet. On examination, we found a Glasgow score of 15, blood pressure more than 180 to 110. The heart rate was 92, oxygen was normal, as well as respiration rate. She had a body mass index of 34. She hadn't neurological deficit, no signs of heart failure, normal peripheral pulses, and on ECG, the rhythm was sinus, there is sinus rhythm, and left ventricular hypertrophy. Here we can underline some elements that orient to a hypertensive crisis or that favors the occurrence of a hypertensive crisis, like hypertension of long date, other risk factors like diabetes mellitus, a non-compliance, and a high body weight. The clinical evaluation is very, very important tie. And when we speak about diagnosis and management, this is a key. So clinical evaluation is a key tie. We had to inquire about therapeutic non-compliance, like in this patient. It is the most frequent cause of hypertensive crisis. We have to inquire about concomitant medication. Maybe there is an intake of some sympathomimetics or steroids. Stress, anxiety, pain, and fever may be catalysts for elevation of blood pressure. Also hypoxemia, like in COPD or asthma decompensation. In anamnesis, we have to pay attention to red flags, to signs who may orient us to a hypertensive emergency, like unusual headache, visual blur, neurological deficit, dyspnea, chest pain, or vomiting. There were no signs like this in this patient. We have to pay attention to blood pressure measurements and errors. So we give the patient supplementary rest. We remeasure the blood pressure with a totally discovered arm in a supine position with an oscillometric method and an adapted cuff to eliminate all causes of errors. Pseudohypertension when arteries are very stiff is a cause of errors and can be suspected when there is no signs of target organ damage. The measurement should be comparative in two arms. We have to take orthostatic blood pressure, and bradycardia and anemia are causes of an elevation of systolic blood pressure with an elevation of the differential blood pressure. And this is a differential diagnosis, not a cause of a blood pressure crisis. If a patient have a severe bradycardia and an elevated systolic blood pressure, and we act on his blood pressure and lower his blood pressure by medication or aggressive medication, it can put him in a shock status or even death. So we have to correlate the numbers that we found with heart rate and search also for signs of anemia. which will lead to the same situation. We have to search for impact on organ damage or target organs, heart failure, neurological deficit. Urinary strip is important for proteinuria and hematuria, and IFANDS is capital here. We will speak about this later. So which workup for this patient, for this kind of patient who comes to emergency room with elevated blood pressure? Usually we do non-specific workup like ECG, creatinine, electrolytes, hemoglobin, hematocrit. This is a current workup. For when specific complication is suspected, for example, in acute coronary syndrome, because the patient have a chest pain or there is an ECG signs, we complete by cardiac biomarkers. When we suspect the aortic dissection, we will do an angiotomography. For stroke or cerebral complications, we will do cerebral imaging. So the other workup, it depends on the clinical orientation. Hemolysis is important for malignant hypertension, also acute coronary insufficiency, acute kidney insufficiency. We'll have to do a renal echocardiography maybe. So when we are in this situation, first time is to eliminate a hypertensive urgency, and we think about all the complications, all the situations that will constitute an emergency, like aortic dissection, acute coronary syndrome or heart failure, stroke, encephalopathy, malignant hypertension, rather called retinal papillary edema and hemorrhage now, and acute kidney insufficiency. If there is no one of these complications, we will speak about hypertensive urgency. Before treating, we have to think about this of the physiopathology, particularly the physiopathology of cerebral flow. In a hypertensive person, the curve of the cerebral perfusion is shifted to the right. So if we, for a patient who has a hypertensive urgency, he is still on the plateau. He doesn't have a risk of immediate complications, fatal complication. On the contrary, if we aggressively lower the blood pressure, we can compromise cerebral flow, and blood pressure of 120 or 30 or 40 maybe for hypertensive patients, it may cause insufficient cerebral flow and cerebral ischemia, and this is really harmful and can cause complications. So when we treat a situation of hypertensive urgency, the patient is not hospitalized. It is an ambulatory management, but we need an observation time and monitoring before taking this decision. We need to observe the patient, control blood pressure level, make a usual workup, and then it is strictly forbidden to use in this situation intravenous or sublingual medication. Rest is treatment. We keep the patient at rest in the consultation, or we prescribe time of rest at home. We have to relieve stress and anxiety, and when we explain to the patient that there is no immediate life-threatening for him, it is a reassurance for him, and this can relieve his anxiety. Sometimes we need even medication to relieve its anxiety when it is intense. We have to correct all catalysts like automedication or non-compliance. For the treatment of hypertension, maybe we will only recover the current treatment if there is a previous control of hypertension and there is a missed intake in the last days. But if we ask the patient and he was never controlled, maybe we have to intensify his medication immediately and to target the aim is to have blood pressure in target in 24 to 48 hours. We will schedule a rapid first visit and a close follow-up by his family doctor, and multidisciplinary management is often needed because there are often patients with many comorbidities like diabetes, renal insufficiency, etc. Therapeutic education is key here. It is really the most important thing for compliance to treatment, for alcohol intake, possibly smoking, like in this patient, cessation. So we have to insist on smoke cessation, low sodium diet, exercise, aerobic exercise is very important, and compliance to treatment. So here is a summary. For hypertensive urgency, it is an elevated blood pressure without organ damage, acute elevation, but no organ damage. First step is to make the differential diagnosis, and the first differential diagnosis is the hypertensive emergency, and to identify catalysts, to assess cardiovascular and global patient risk, to revise the therapeutic scheme, and to insist on therapeutic education, and then to go to a usual hypertension care with a first-line care, but with a close follow-up. Hypertensive emergencies are not life-threatening immediately, but they impact the long-term prognosis of the patients, and the all work to do is here, is on the long-term control of blood pressure and other risk factors. Let's go now through the second case. It is a male of 64 years old, and he was brought by his family because of confusion and vomiting. The family signaled a headache from 28 hours. The anamnesis were really difficult. He was not able to answer the questions. Glasgow score was 13, heart rate 110, blood pressure was very elevated, and we see here diastolic blood pressure above 130, and respiratory rate was 26, oxygen was 95, sorry, BMI was normal. There is signs of left heart failure, pulmonary crackles, no neurological deficit, proteinuria and hematuria on the urinary strip, and left ventricular hypertrophy on ECG. This is a workup, and there is an elevation in creatinine, low potassium, low sodium, low hemoglobin, low platelets, LDH, lacticodehydrogenase elevated, troponin mildly elevated, and the echocardiography showed a normal ejection fraction and no regional kinetic abnormality. And Importantly here, the eye filters, which showed retinopathy state 4 with papilledema and retinal hemorrhage, like as we see here, the edema and the hemorrhage. So here we are in a different setting. Here we have an abrupt elevation of blood pressure with a diastolic pressure more than 130 with target organ damage. So it defines a hypertensive urgency. The patient should be taken immediately in the ICU. And the same reasoning, in fact, the same reasoning is applicable here, and the physiopathology of cerebral flow is here to be taken into account. We have a hypertensive emergency. So the curve is in the upward R here, but still we should lower very aggressively blood pressure until arriving here and cause cerebral ischemia. The lowering of blood pressure in case of hypertensive emergency will be from a few minutes to some hours. It depends on the which target organ is damaged and which is the clinical situation. For aortic dissection, it is the situation where we need the most rapid and aggressive intervention. Systolic blood pressure must be inferior to 120 in 20 minutes. And we have also a target of heart rate. We should have a heart rate less than 60 beats per minute. In the other situation, the lowering of blood pressure will need titration, and it will be done in 1 hour here to 6 hours. So in 1 to 6 hours, we will have to lower blood pressure by 15 to 25%. And the target blood pressure will be achieved in 24 or 24 hours in general, not immediately. This depends on the situation. For stroke, we have to, the target blood pressure is mean blood pressure, and it is lowered by 15% in 24 hours if the blood pressure is more than 220. If it is not above 220, we respect this blood pressure in the first hours of a stroke, unless we have to do a thrombolysis. And if we have to do a thrombolysis when the presentation is early, so we lower blood pressure if it is more than 185. When there is a hemorrhage, also we lower blood pressure only when there is systolic blood pressure more than 220. In our patient, we are here. We are in a situation of encephalopathia or malignant hypertension. And in this case, we lower blood pressure by 15% in the first hour. Then we need to have a blood pressure less than 160 over 110 in 6 hours. And as I said, we reach the target blood pressure only in 24 hours. We use intravenous medication, not classical antihypertensive molecules. So all these molecules are given intravenously.
Fatima, you are running out of time. You are running out of time. Please conclude in next 5 minutes.
Okay. So for our patient, we have a malignant hypertensive. So here are summarized the management of a hypertensive emergency with different steps we saw. It is important to differentiate between hypertensive urgency and emergency, to be careful with the clinical examination and workup. The rapidity of blood pressure elevation is most important than the number. In case of hypertensive urgency, non-compliance should be eliminated. In case of hypertensive emergency, it is in general a secondary hypertension, and it was a secondary hypertension in our patient. Urgencies impact the long-term morbid mortality, while emergencies are immediately life-threatening. And the management is ambulatory for urgencies, while it is in ICU for emergency. So we don't have to see only the numbers, we have to pay attention to the patient as a global. And it is also important to educate the citizens and all people about this question. And the care is multidisciplinary. It includes all the health system, all the health workers, and all the health system can take care of these patients. Thank you very much.